Hello, welcome everyone, and thank you for attending today's Public Health Communications Collaborative monthly webinar. Today's webinar is the Public Health Workforce, Morale, Mental Health, and Moving Forward. I'm Sarah Waddell, the Chief Medical Officer of the CDC Foundation. As always, we try to select the topics that will be of greatest interest and support to you. Now, nearly a year and a half after the onset of the pandemic, communities across the country continue to be overwhelmed by the fight against COVID-19. The people behind the fight, the public health workforce, remain heroic in their efforts to keep our country safe. Today, we pause and ask, how do we protect the health of those in public health? Today's webinar will address the ongoing challenges of dealing with misinformation, political divides, and even harassment that the public health workforce has faced throughout the pandemic. We'll provide a space for candid conversation, dialogue, and resource sharing to help public health officials support their workforce, their colleagues, and their own mental health. We are thrilled to have three esteemed panelists with us today. Dr. Jeanette Kowalik, the Director of Policy Development at the Trust for America's Health and the former Commissioner of Health at the City of Milwaukee Health Department. Dr. Benjamin F. Miller, the President of Wellbeing Trust, and Dr. Wilmer Wooten, MD and PhD, the Public Health Officer of Public Health Services in the County of San Diego Health and Human Services Agency. During the presentation portion of the webinar, please feel free to submit your questions in the chat by sending a message using the Q&A button at the bottom of your screen. Our speakers will have time to answer several of those questions. And as always, today's webinar is being recorded. That recording will be available at the Public Health Communications Collaborative website later this week, along with all previous webinars we have held and other COVID-19 communication resources. Now, before we get started, we want to give our speakers a sense of who is participating today and your most pressing communications challenges. This will also help them answer your questions later and help us plan for the future. So in the Zoom pop-up box, please answer these questions. Which term best describes where you work? National Governmental Public Health, State Health Department, Local Health Department, a public health non-governmental organization, a healthcare facility, a K through 12 school system, the university or higher education. And also tell us, what is your most pressing communication challenges? Whether it's around vaccine distribution, vaccine confidence, safety precautions, the trust in public health, message consistency, or health literacy. So you've got about probably 30 seconds left to answer these questions. Which term best describes where you work? And what are your most pressing communication challenges? You've got 10 seconds. Great, we're seeing where people are also chatting in if they're not able to complete the poll, so we welcome that information. And we should see our results coming up here just short. Here we are. So, which term best describes where you work? As you can see, we have a large contingent from local health departments, about 51% of our audience, followed by state health departments in terms of about 24%. And then several other partners here, whether it's from the school system or universities and non-governmental organizations. And then what are your most pressing communication challenges? As you can see, the issue around vaccine confidence remains an important topic, as well as trust in public health, consistency in messaging, all the things that we have heard and continue to hear and need to continue to work on together. And also I see that people are putting things in the chat box, such as health equity. Okay, so thank you for sharing that, and that should be helpful information to our speakers. So now we're going to move forward to begin to hear from our impressive speakers. First, we're going to hear from Dr. Wooten. Dr. Wilmer J. Wooten is the Public Health Officer of Public Health Services in the County of San Diego Health and Human Services Agency. She has been with the County of San Diego Health and Human Services Agency since 2001, initially as the Deputy Health Officer and now as the Public Health Officer since February of 2007. She has held several board roles across the field, including the California Conference of Local Health Officers, the Health Officers Association of California, has also served as on the advisory committee to the director of CDC, and with the National Association of County and City Health Officials, NACHO. Dr. Wooten is a current board member of the Public Health Accreditation Board of Directors and chair of the Big Cities Health Coalition. Dr. Wooten, thank you so much for joining us today, and we look forward to your remarks.
Thank you, Dr. Waddell. If we can move to the next slide, I'd just like to acknowledge the impact of all of the emotions and situations that people have been experiencing throughout this pandemic. In San Diego, we responded in 7 ways to the pandemic, and I'm today going to focus on our involvement with our sector partners, as well as our communication internally versus externally. In the next slide, in relationship to our, if we can go to the next slide, in relationship to our internal communication. Next slide. So as a result of the issues with that happened last year with George Floyd, our county conducted listening sessions for all of our county employees to help them deal with what they were feeling. And even locally, there were riots associated with this incident. More internally with our public health staff, we would convene check-in sessions with the staff. And you can see here it would include just overall updates, icebreakers, sharing by our units within our administrative branch, and then providing information for self-care. In the middle of this slide, it shows at the time we were on stay-at-home orders. So it gave people an opportunity to take virtual tours in our local parks and trails. Focusing on external communication, in the next slide, and continue. So we leveraged the Live Well San Diego sectors, businesses, community and faith-based organizations, governments, as well as education or schools, and parlayed those and expanded them into 10 other community sectors and 13 subsectors. In the next slide, it shows, next slide, these were the strategies. The prior slide showed the strategies of how we communicate with those sectors, whom we met with either on a weekly basis and ultimately bi-weekly, and then maybe even a monthly, which is where most of them are now. In the next slide, it speaks to the, we convened focus groups of these sectors to find out who were the most vulnerable populations. And this is what we came up with. And as a result, it led procurement. And we identified in the next slide 4 groups that we would focus on in the center of this slide: Asian and Pacific Islanders, African Americans, as well as refugees, and Latinos, of course, because they were the hardest hit individuals. And in the remaining slides, I'm quickly going to go through those. I just want to share with you, we had a 2020 media campaign that were in several phases. First, we focused on the stay-at-home orders, social distancing, and face coverings since we didn't have vaccines at the time. Then the next phase was these orders were lifted, but we wanted people to continue the preventive strategies. In the next slide, phase 3 is focused on addressing the increasing number of positive cases, particularly in our Hispanic community. And then we utilize testimonials from individuals that had COVID so that the public could learn, and hopefully that could help entice people to adhere to the strategies that were being promoted. And then in the next phase 4, which is our final phase of the media campaign, we continue to focus on those strategies, and we're getting ready because the vaccines were coming available, first being available on December 14th in San Diego. We were beginning to focus on our vaccine campaign. In the next slide, or my remaining time, we had 2 surveys. The first came after in December, and it really focused and identified the fact that the most hesitant individuals were African Americans under 50 years of age. And out of this came a project that was identified by our community health worker collaborative called Project SAVE. And in the next slide, this was utilizing our partners to go into the communities in our south region of the county and to identify those people that were not IT savvy and to help them schedule appointments at these 4 sites in the southern region. In the next slide, in my remaining 2 minutes, I want to just briefly talk about the vaccine campaign. So we focus on marketing assets to promote awareness about the COVID-19 vaccines, particularly on the 65 years of age and older. In the next slide, we focus on the next groups that were available, 16 to 64. And then that was in phase 2. And in phase 3, it came out that our Gen Z population, 18 to 25, also needed a different approach. And in the next slide, this was a second survey we utilized funding from our Health Disparities Grant. And here we identified, there were 3 subpopulations that were identified: individuals who needed a second dose, vaccine hesitant individuals, and those that were resistant. So in the next 2 slides, we basically framed our vaccine campaign around those results, and also particularly vaccine hesitancy. And then in this last slide, just wanted to show that out of our youth sector, they came up with the idea to create a challenge, and it was entitled "Our Health is Worth a Shot." And there was open competition for youth to submit videos or visual art challenges, and these are the 7 winners. So with that, I'll turn it back to Dr. Waddell.
Well, thank you so much, Dr. Wooten, for sharing those remarks and the incredible work that you all have been doing in San Diego. You certainly highlighted the importance of listening sessions, communicating with your staff, engaging multi-sectors, getting data and information, and then framing your response around that. So thank you. And I'm sure people will have questions about the campaign for developed and designed by youth. So thank you very much for that. So now I'm delighted for us to hear from Dr. Kolwalik. Dr. Jeanette Kowalik began her career as an intern in the city of Milwaukee Health Department in 2002 and returned to serve as the Commissioner of Health from 2018 to 2020. The highlights of her career to date are collaborating to declare racism as a public health crisis in July of 2019 and prioritizing the impact of COVID-19 by race and ethnicity in Milwaukee, which motivated other jurisdictions to do the same. Dr. Kolwalik returned to Washington, D.C. in late 2020 to serve as the Director of Policy Development for the Trust for America's Health, a nonprofit and bipartisan health policy organization. Dr. Kowalik, the floor is now yours.
Great, thanks, Dr. Waddell. And thank you, Dr. Wooten, for sharing what you all have been able to accomplish in San Diego. So if we can go to the slides, and just to hold on this slide, the first slide, if you go back to the title slide, I just want to use that as a prompt to dive into this conversation. So this picture is from our very first press conference about COVID, which was at the end of February in 2020. And the reason why I selected this piece, because it just it captured the essence of what was to come. And many press conferences, many interactions with the community, various partners in Milwaukee County, the state, regionally, nationally, just nonstop from that point forward. So I just want to acknowledge everyone that has been a part of the local COVID response, as well as the state COVID response, past, present, and then individuals that would like to join the movement, because obviously we're still in this pandemic and we're not out of the woods by far. Next slide, please. So this is just to give you a sense of what the Trust for America's Health is about. As Dr. Waddell noted, I'm with the Trust for America's Health now. So I'm helping the pandemic response from a different angle, able to do more nationally than what I was able to do locally. Next slide, please. So some people don't know where Milwaukee is located, so I always think it's important just to highlight this, as well as to give a shout out or props to the Milwaukee Health Department, which was the home of my public health career as an intern and eventually coming back as a commissioner. So just noting what Milwaukee's about, the composition of Milwaukee, noting that there's a county and there's a city. It's an important distinction to make, because the city is where the majority of the people live in the county, as well as the most diverse area in the county as well. So just acknowledging that sometimes you'll hear city and county interchangeably, but also noting that there is no county health department for Milwaukee. There's a city health department, and then there's 11 other health departments in the county, which represent either combined for various jurisdictions or singularly for their own jurisdictions. So there is a lot going on, a lot of dynamics and navigating politics to the max. And I also just want to shout out that Milwaukee, if you are not familiar with it, you should know that it is the home of the world champion Milwaukee Bucks. So just shouting out my team. Next slide, please. So as noting what Milwaukee's about, you see it's located near, or it's in the Great Lakes or Region 5 area. But Milwaukee has a high history of segregation. So just looking at the impact of policy related to housing and health outcomes, if you swap these heat maps out, they're pretty much the same. You see the brunt of disease, violence, obesity, so on and so forth in the inner city, which is still where the majority of the Black community resides. And then as you see on the right here, this is a COVID map from when I was preparing to transition out of the role in September of 2020. At the top northwest part of the county is still city of Milwaukee now, but there's a large amount of long-term care facilities and assisted living areas in that region of the county. So just noting that that area was hit hard eventually as well. And then the southern part of the county, those areas are predominantly white or Latinx, and we were starting to see a rise in cases and deaths in those areas. But those, from my recollection, were more so related to people that were not following public health orders, as they didn't have them in those southern parts of the county, but also not taking just basic precautions of distancing and masking. So noting some of these comments I see about anti-vax, just anti-public health, just really seeing a lot of resistance in that area, as well as the rest of the country. Next slide, please. So this is just to show you some of the data. This is from Stanford. This has been updated as of this year, I believe, but just showing when you look at segregation experience and by where people live, Milwaukee is the highest. It's at the top right corner of this chart here. And that creates another layer of dynamic in the city and the county. So just putting that out there of all of the stressors and all of the challenges that I experience, as well as those that are still working in public health in the area. Next slide, please. So these I'm just going to go through very quickly, but just to give you a like Instagram-ish type of review of the pandemic response in Milwaukee in 2020. So at first we were like bracing because we were already preparing for the DNC in 2020. We were convening, meeting with partners. So we already had our public health emergency preparedness plan. We were still in the process of hiring staff, but just really building things out we were in motion to do that. The department was also, and still is, in a state of rebuilding because of some issues in the past. So acknowledging that that was another layer, as well as going through a whole updating process of the department reorganization process. So those things were happening, and then COVID hit. So if you can imagine, it's just like the perfect storm of challenges for a health commissioner or health official. But just acknowledging here, the mayor, Tom Barrett, in this lower left picture here, and then the one where it says Milwaukee County standing to the left, that's Chris Abley, the former county executive for Milwaukee County. Next slide. So here, I wanted to just acknowledge some basic things. You see these individuals, which you can see vaguely, standing over the ledge. We were in the process of hiring and bringing on our executive team when the pandemic happened. So these individuals ended up joining the team, even our medical director, in April of 2020. Our first case was March 13th, Friday the 13th of 2020. But just acknowledging that not even having your core leadership team really created a huge disadvantage for us moving into the pandemic. So we were scrambling to fill positions. As you know, when it comes to government, sometimes it takes a long time to hire people, especially if you're negotiating salaries and benefits and all of those things. The other pictures are just some of the self-care things that I really gravitated to, and this little I showered sticker is a big one, because we were working 20-hour days, and just taking a shower and getting dressed. And even for me, because I had to do media, I had to get camera ready all of the time. That was a big deal for me. It's very tiring to do that, but just acknowledging that is an accomplishment. And then taking care of yourself. You know, a lot of the salons were closed, doing your own nails, getting flowers, and takeout was a big thing. This meal here is from a place called Elsa's in Milwaukee, and it was the last meal right before our order took effect, which closed all of the restaurants and bars to prevent the spread of COVID-19. But that was the last meal. It was a sad meal, but just acknowledging, supporting local business, and still making sure we're eating good food was something that I did quite often. Next slide, please. So here, I ended up having to go through reconfirmation as a commissioner in July of 2020. So adding that to the plate, DNC is at the bottom here, where you see these individuals standing up. And then my first CNN interview, which was a big deal because it's just putting out the information, what we have rang the alarm on as far as inequities with COVID cases and deaths among our Black and eventually Latinx community in Milwaukee. So just really ringing an alarm that this was happening, that we needed to do better with outreach messaging, and acknowledging that the inequities were pretty much set up due to the systems of racism in our country and segregation, that until we dismantle those things, we would continue to see the same things time and time again. And I know I'm preaching to the choir. You all have experienced this in your communities with those that are being hit hardest, being groups of color, indigenous, refugee, so on and so forth, but really acknowledging that, you know, a lot of these people, like I'm from Milwaukee, I grew up in Milwaukee. These are people I knew that were dying or being impacted. So still having to show up and save face and not having time to grieve was just something that I just couldn't have even prepared for. So it's something I'm still processing now. Next slide, please. So eventually I ended up leaving the Milwaukee Health Department, and just acknowledging that some of the challenges of being in a highly segregated area also makes one target of various threats, racism, just nasty messages and things like that. And I know many of you have been being hit and targeted. So I just want to appeal to you and let you know that you're cared for, you're loved, you're protected. And from those squeaky wheels that were trying to hurt me, that more people had showed up to protect me and support me. And I found out after I resigned. So it's like getting your flowers while you're alive, just acknowledging that people need to do a better job of expressing their appreciation and value for us as public health professionals while we're in the job and not waiting until we leave the job. But these are just acknowledging some of the things, this Bloomberg piece that I did, acknowledging this experience that I had through the Daily Beast, which I wrote right as I was leaving the position, and then transferring the commissioner role over to one of my colleagues, Marlena Jackson. So she ended up taking over as interim commissioner. Next slide, please. And then once I was out of the role and I became a member of the Trust for America's Health, I felt that I was more at liberty to discuss what I felt about the experience of being a health commissioner, a public health professional during these trying times. So these two pieces here, if you haven't read them yet or listened to them, please check them out. But one is in the American Journal of Public Health and the other is the Journal of Public Health Management and Practice. Next slide, please. And lastly, the call to action, and I know my colleague, Dr. Miller, will talk more about mental health, but just keeping it simple, assessing your intentions. Why are you in the role? Why are you staying in the role? And what are you going to do when you feel like your boundaries have been violated and it's time to leave? Assessing your sense of duty and worth is more than a title. I know sometimes our ego really gets in the way of that, but acknowledging that if you're causing harm to yourself, at some point you're going to have to say goodbye and take care of yourself. You can't pour from an empty cup. And then recognizing that we are in a wild pandemic. And if anyone guessed that people would be protesting and trying to tear down vaccination sites and everything that's happening right now, it's just unbelievable. So just acknowledging that this is abnormal, what we're experiencing right now. So giving yourself grace and kindness to yourself as well as to your colleagues. And then eventually, if you feel the need to leave, being able to share your story. There's a lot of power in storytelling and just acknowledging that. We promote this for policy when we want, policymakers to get on board and support new acts and bills and laws. We have all the storytellers. We should also feel that we can tell our own stories too. So I just want to appeal to you all to encourage you to share your stories. And if you feel that you can't now while you're in the role, please journal and come back to it at another point. Next slide, and then this is it. So lastly, just thanking everyone. Trust for America's Health has been wonderful, and I'm still able to give back to the pandemic response. But I just want to acknowledge very, very quickly, because I know we're over time, is that because of the stress and the toxic experience that I had as a health commissioner, I have multiple autoimmune conditions, and eventually it caught up with me. In like January, February of this year, my health declined rapidly, and I had to go off on leave of absence for 6 weeks and eventually got back into full-time work. So I just wanted to point that out, that you may think that you're okay now and it might show up later. So I just want to thank the Trust for America's Health for giving me the time and space to heal. So I just wanted to put that out there, that please take care of yourselves. You are loved and appreciated. Thank you.
Wow. Thank you so much, Dr. Kolwalik, for sharing your care and your passion and the courageous work that you led in Milwaukee, and that you continue to share with others all across the country. You certainly highlighted the importance of engaging others, and that these interactions will need to continue, the importance of self-care, the sense of duty and worth, and really assessing that, understanding your mission. What is your mission and your vision? And then the importance of telling stories. But the overarching piece here, I think, is that it takes a lot of courage to lead during these tough times, and that can certainly take a toll on you as a public health leader, and acknowledging that, and for others to understand the value and the importance of that is really important as we continue on this journey and this hard work. So thank you again. It is really my pleasure now to turn the podium to Dr. Benjamin Miller. Dr. Miller is the president of Wellbeing Trust, a national foundation committed to advancing the mental, social, and spiritual health of the nation. He oversees the implementation of the foundation's strategies and four full portfolio of investments and partnerships to help Wellbeing Trust have a real-world impact on America's mental health and addiction crisis. Prior to joining Wellbeing Trust, Dr. Miller spent 8 years as an associate professor in the Department of Family Medicine at the University of Colorado School of Medicine, where he was the founding director of the Eugene S. Farley Jr. Health Policy Center. Dr. Miller, we look forward to your remarks.
Thank you, Dr. Waddell. And it's just so hard to go third. And I want to respond to what my esteemed colleagues have just said. But I'm going to take a moment and just really focus in on what I was asked to talk about today. And I'm honored to be in a position to talk about the issue of mental health and realize that this is a hard topic to cover and even sometimes an even harder conversation to have. But the issue of mental health in our society is one that has been marginalized and ignored for too long. In some ways, it's kind of like climate change and what feels sometimes like this frank disregard for changes that are happening right in front of our noses, and we don't pay attention to them. Our nation's lack of attention to the issues of mental health and addiction have placed us all in a dire position. So today with my time, I want to briefly talk about our context and dive into a few ideas on solutions. Next slide, please. So in preparation for today, I just searched some recent headlines, and I think they say it all. Here's one. Healthcare workers aren't heroes, we're human, and we need your help. Here's another. A sinking ship, pandemic's mental health continues to roil healthcare workers. Another, 1 in 5 healthcare workers almost quit their jobs during COVID-19. And then some just more generally around mental health, where you see headlines about, we're talking more about mental health care, but what are we doing about it? Or the impact of COVID-19 on poor mental health in children and young people is just the tip of the iceberg. And I could go on and fill the rest of my time just with headlines. I think it's clear that our country is hurting. It's in pain, and the frontline clinicians, our workforce, who are often responsible for the healing, are also hurting. They went from being celebrated to being villainized, and this has taken a profound toll on their mental health. However, solutions seem to be in short supply, and we all know that the cost of doing nothing is catastrophic. The long-term impact that the current trauma could have on our nation will be felt in all communities, though, as my colleagues have pointed out, not all communities the same. Recent data from the Morning Consult shows that 51% of healthcare workers said their mental health has gotten worse during COVID, up from 46% who said the same in January. Another 42% said their day-to-day lives have suffered during the pandemic. And in work that Wellbeing Trust funded in collaboration with Kaiser Family Foundation, we found that in July of 2020, about half the country reported worry and pandemic-related stress that had negatively impacted their mental health. And even with shots in arms this past summer, 47% of adults still continue to report negative mental health impacts. And to add insult to injury, about a third of this group also reported unmet needs for their mental health care. Next slide, please. So all of this is on top of the pre-existing problems we've had as a nation, where we roughly lose one person every 3.5 minutes to preventable cause. Over 156,000 lives were lost before COVID in 2019 from deaths to drug, alcohol, and suicide. Kids are suffering. Hospitals are declaring mental health crises. We have each felt mental health in more profound ways now than ever before. We knew that there were problems with mental health before COVID, but this moment gives us a propitious moment, a unique time to act. But where do we start? Well, I'm going to spend the rest of my time talking about our workforce, but perhaps not in the way that you think. Next slide, please. So I want to put in a gentle reminder that as much as our country needs help and care now, there are profound barriers to getting people access to care. People have been calling out for help for a long time now, yet treatment and mental health services have not met the demand and aren't meeting people where they are. In reality, if you look at the data, only about 1 in 10 people with a substance use disorder receive recommended treatment. And according to another survey from Kaiser Family Foundation, about 39% of American adults have delayed accessing healthcare because of concerns of cost. And 4 in 10 adults with insurance, they have trouble even affording their deductible. Next slide, please. All of that brings us to this moment today. We need to have a national dialogue on where we want to go as a nation for mental health. In the face of this crisis, how can we not go back to the way it was before the pandemic? How can we look at our problems, no matter how big they are, and put forward thoughtful solutions for a new structure for addressing mental health? The beginning of advancing a new vision is communicating what it is and how the general public can be more aware of the power of this change. For example, I routinely will challenge policymakers and administrators to reassess their policies, even their administrative and financial structures, to see how they reinforce a fragmented view of mental health. Better mental health integration should be our goal. In any communication that we have about the pandemic, to not address the underlying and often profound effects on our mental health is to our detriment. Just as much as we market our strategies around testing and vaccination, we too should be thinking about the messaging on what to do when you're scared, you're anxious, you're depressed, you're using more, you're drinking more, you've had suicidal thoughts, you've lost a loved one, and so much more. I think this could go a long way in helping better enable folks to have a conversation they've been needing to have on mental health. Next slide, please. So as seen on this slide, mental health services exist on a continuum. This continuum does not imply a hierarchy, but really is rather there to show the interconnectedness between various elements of our workforce and how they are able to complement one another. One of us will have needs that fall on the continuum somewhere, all of us will, depending on our willingness to seek services, our health insurance coverage, and overall severity of need. So as we work to communicate more broadly about the impact of COVID on our mental health, let's also use this as a moment to reconsider our structures and the role and function of our workforce. I believe there needs to be three major shifts in healthcare workforce to address this moment and the increasing demand for mental health and addiction services and the heightened limited capacity that we've seen. Number one, we have to have a shift at the clinical level to manage more mental health and addiction services in places like primary care. Number two, we need a shift at the community level to expand the community-based workforce in mental health and addiction care across clinical and public health settings. Community health workers, peer support specialists, navigators, contact tracers, and the like. And finally, number three, we need to have a shift at the individual level, our level, where we sit as individuals, to train each other in low-level psychological interventions, which can include our own public health workforce. What happens when we're better equipped to have interventional skills to help one another? These shifts away from the top should not be seen as replacing much needed access to healthcare or clinical services, but really as complementary support through community-based structures for a system that's way too overburdened. This approach may provide sufficient level of care for some and an entry point for clinical care for those who have needs. So on this slide, you can go to the next slide. Care should be where we want it to be, where we show up. This is as much for the patients in our community as it is for our frontline providers. Wellbeing Trust, for years alongside partners, has been working to define a vision of how to bring mental health to where people are. This includes the places that you see here on this slide, schools, prisons, and even our workplaces. How are we showing up? How are we bringing mental health services to these places? Are we doing more than we did prior to COVID, staying the same? Next slide, please. So let's ask ourselves these questions as we all work to heal our nation and to work to recover from COVID. For mental health, what are we doing? Where are we doing it? Who is doing it? And how are they doing it? This democratization of skill and knowledge is so needed. There are concrete steps that we can take today to help achieve this vision. We have to reconsider the design and capabilities of our workforce. Since demand for care has far outpaced the supply of clinicians, as I mentioned, it's inconceivable to simply rely on clinician recruitment strategies alone to meet the ever-growing need for care. So here are two things we could do simultaneously to address this moment. First, it's really important that we map out mental health utilization and gaps to best determine where services are needed and for whom. This is essential. Public health is built on a foundation of data. Do we have these data about our own employees? Without these data, we run the risk of putting money into places and programs that people simply will not use. Second, and ideally, we want to invest in our community workforce. Those like peer support specialists, community health workers, as I mentioned, and also just more broadly about lay people who hold no formal role or title. We can train entire communities up in mental health skills to help become a front line of mental health support, complementing our clinical enterprises and enhancing the overall capacity for communities to address mental health needs. This will shape how we communicate about solutions and how we discuss and advocate for change through public policy. Next slide, please. So in closing, this is our moment to embrace mental health for what it is, a core and essential component for our health, not an afterthought, not an add-on, but an essential element for our health and well-being. It should be front and center in any and all strategies from our recovery for COVID, as well as our communication on our goals to work to achieve population health. For our frontline workers who need mental health supports, to each of us, it's time to be bold in our action to radically pursue strategies that can change this nation. It begins with us today, naming mental health as a priority and following up with it with strategies. Thank you so much.
Well, thank you so much, Dr. Miller, for those remarks. In posing the question, how do we show up? How do we bring care to where people are? all across our communities, and how mental health is really integral to all of what we do. And how do we change things at the clinical level, the community level, and the individual level? A lot to unpack there, a lot to think about. So we have heard from all of our panelists. We want to remind you to submit your questions in the Q&A function below. And while you're doing that, we do have time for some dialogue with our panelists. So I want to get us started with this question. So we've heard some really important conversations here about supporting the public health workforce, prioritizing mental health, and building resiliency within the workforce. So given that, how would you recommend public health leaders creating space to share these important messages with their organizations? Let me start with Dr. Wooten, and then we'll go to you, Dr. Miller, and then Dr. Kolwalik.
Thank you, Dr. Waddell. I think I touched on it at the opening of my presentation, creating a space where you can have employees come and just be in a safe place to discuss whatever is bothering them or whatever issues they're being challenged by. I think that says a lot, but also I think it's important, and I've always promoted this even before COVID-19, is to take time off for yourself. I think that's very vital and very important. But again, and then offering opportunities for people to take care of themselves, whether it's taking vacation or the example I gave, the virtual parks and trails, because at that point in time, we were on basic lockdown. So, but whatever it takes to help rejuvenate and re-energize your spirit, I think is important. Thank you.
I love those comments, Dr. Wooten. I agree with you. I'll just add a couple more. Sometimes being in a position of leadership means you have to put yourself out there. And that oftentimes means being transparent and describing your own issues that you might be struggling with. The issue of mental health is one that I think we could embrace a whole lot more as leaders. And so I'll give you just a couple of things that I think we could do there. Number one, we got to lead with our own experience and describe, to others, our employees, those that are looking to us, how we're doing, and model what that looks like. Model that it's okay to not be okay. Model it's okay to talk about mental health. Model that it's okay to take a day to yourself. Okay, that's number one. Number two, we got to be considerate of our language. In any communication that we have, if we're not integrating the words mental health within our communique, sometimes that's going to lead people to the wrong impression that it's not a priority. And I think that we have to have language that reflects this moment. And then number three, I think that we have a responsibility to really look at the systems and how sometimes systems place people in a position where they do get burnt out. We work a lot with frontline clinicians, and we talk about this a ton. There's nothing more infuriating as a frontline clinician to simply be told, well, here's an app for that, or here's the new program that we're going to add in our workplace. Without recognizing sometimes the burden that we place on individuals and the stress that they feel from just their day-to-day jobs, and how sometimes we enable that. We're not looking at those systemic issues that will plague our workforce even beyond COVID. So those are just three things I would probably begin to pursue.
Yes, I agree with everything that's been shared so far. I also want to acknowledge that most government offices have EAP, someone that you can go to when you are experiencing stressful situations or whatever. But normally, because like Dr. Miller said, that's underfunded and the resources are limited. Like in Milwaukee, we just had one person. So one person for everyone in the city, or the health department, it's just not enough. So acknowledging that although those resources are out there, there needs to be more intentional investment in increasing access to those types of services, especially services that are culturally appropriate. Another thing too is assessing staff and finding out what do people want, what do people need. We knew like telework was something that was offered at our department before the pandemic, but definitely we scaled that up acknowledging that certain positions couldn't be telework. Like we kept our STI HIV clinic open the entire pandemic. And we knew that there was a lot of sex happening, so people needed services. So we wanted to make sure that that was available to the community, but noting just because staff are providing direct service doesn't mean they can't benefit from telework. Give them a day or two or rotate where they can maybe just do charting or professional development or anything like that. Just, acknowledging just because you're direct service doesn't mean you're 100% always direct service, that there might be time for you to be offline so that you're not directly seeing clients and you can use your energy in a different way. So just acknowledging those two things, listening to your staff, putting a survey or assessment out there, what will work, what kind of benefits would be useful, and then acknowledging that EAP is a resource, but it tends to be under-resourced. So acknowledging that. I appreciate the comment about being authentic and real and sharing with your staff how you're feeling and what you're experiencing, and not being anal or very black and white about policies and procedures. Of course, when you're delivering healthcare, there's things you have to do. But for instance, start times, if you're not opening the clinic up, why are we beating people down if they're 2 minutes late? I mean, there shouldn't be any of this going on right now, because we need to be graceful and extend kindness to one another and acknowledging that we're going through a lot. So things shouldn't be treated as normal. So I just wanted to leave on that note.
Great. Thank you all for those responses and those insights. So we have a question, well, actually several questions from the audience, but let me start with this one. So we have a colleague from a state in the Northeast and who says, as the agency lead for workforce development and employee engagement, I find that I'm in a new territory related to shaping a concrete support system for our teams, inclusive of tools, resources, and safe spaces for unpacking the experiences of the past 18 months. Is there a list of resources available for those of us attempting to address these needs? Suggestions on resources. And Kolwalik certainly mentioned, start with your EAP is certainly a place to start. So what else?
I can just mention some things that I did that I found were useful, but of course, insurance doesn't cover these things. So using alternative methods like Reiki and acupuncture and massage therapy, and seeing if there's ways to create partnerships to increasing access to these services for your staff. I know through the domestic violence and intimate partner violence area in Milwaukee that they actually have someone that provides Reiki on site in Milwaukee to their staff, because acknowledging that that's an extremely stressful job before the pandemic, but let alone in the pandemic. So just being open to doing some things differently and not just sending people to therapy. Therapy's great. I strongly support it. I use it on a regular basis, but acknowledging that there are some other types of therapies and treatments and activities that people could benefit from that aren't necessarily covered by their insurance.
Also, another potential resource, if you have it at your jurisdictions, would be to utilize the knowledge and training or training and knowledge department within human resources. Here in San Diego, that particular department helps us if we have trainings that we want to push out to our staff. We develop the core components of the training, and then we develop a learning management system vignettes that we can push out as we have new people come on board. So I think utilizing that resource, if you have it available to you, would be helpful.
And I'll just add one thing. I'll put in the sidebar here a resource that specifically addresses the issues of health insurance that we created, just because of the frustration many people have around getting denied claims for care that they actually need. And one idea that I think has not been mentioned, but I do think is really important, is just providing that flexible, safe space for people to go to when they need a moment. This is not a resource per se. There's a lot been written about this. There's evidence, tons of evidence out there from other employers that have done this type of work. But if there was a safe space that people could go to and just have a friendly ear, somebody they could just talk to about the stress that they're experiencing. One of our friends in Silicon Valley did this at a pretty massive scale. And what they did to demarcate those folks that had received training and helping folks that were under stress or experiencing a mental health crisis, they just had a little dot on their name tag that made them a safe person that they could be talked to by any other employee. Sometimes that opens the door to have conversations that are not going to be had in different ways. Because it's one thing to go to another clinician and have to tell your whole story. It's another thing to go to a colleague that might have a different skill set that can actually be, empathetic to what you're going through, but knows you. And to have them sit there with you in that moment of flexibility, in that moment for you, I think is extremely therapeutic and very healing.
Thank you. I think we've got time for one, maybe two more questions. So let me see if we can cover this. We know that there are many of our public health colleagues that may be working in places where their states seem to be actively going against some of the scientific facts and what are known public health recommendations. And that's certainly impacting the morale of many of our public health colleagues. And not all of our public health colleagues are in positions where they may be able to say, I just need to leave, that they may need to stay, and they may really want to stay, but they're in this environment that's a challenging one for them, impacting their morale. So I wonder if you all could sort of speak to any advice that you would have or important messages that you would share around that. And then I have one final question I want to get in. So if we can touch on this real quick.
This is Dr. Wooten. I'll start. I think it's important for you as a public health official to have some internal mantras and self-talk. One of mine is failure is not an option. Also, you have to remember that we are not political. I know everything we do, there is some type of way to politicize it, but we have to stay focused, stay the course, and keep to what we know is our charge and mission as a public health official, and that is to protect the public's health. So our goal is to provide the advice. Our governing body does the policy making, and we implement the policy. But if we can keep our nose to the grindstone by keeping those things at the forefront, and I think we will serve ourselves well in rising to the challenge to do our jobs, but also serve our politicians and policymakers well too. I know it's challenging in some jurisdictions where the opinions might be different, but I also tell the media, I'm not paid to give you my opinion. I'm paid to give you facts and to help our elected officials and policymakers make decisions. So that's my approach, and that's how I've gotten through this.
Right.
And I can just dovetail on that very quickly, but just acknowledging that, the concern about not giving up, you also have to think about at what expense. For instance, if you know that you have some health challenges or family obligations, many of us are caregivers or caretakers for folks in our family. Providing for yourself and your family is your number one job. And at the end of the day, with this pandemic, I think it's taught us to recalibrate what matters most in our lives. So even within myself, I had to do a lot of, deep reflection and humbling of myself and my ego to finally get to that point of making a move. I mean, acknowledging that I had just got reconfirmed. So I was good technically for 4 more years in July of last year. So my intent was to stay, but the conditions were not setting me up to be able to be effective in that role. And I was also harming myself. and taking away from my ability to be my best self. So just, again, acknowledging the circumstances. I've had colleagues that have switched, areas of the country. They were health officers in one area, they're way across in another region. So if you're in an area that's tough and there's a values mismatch of what you believe in public health and how you were trained to what you're able to do, you may have to move around. And just to acknowledge that there has been many leads that I received as a commissioner in Milwaukee asking me to be a health commissioner in other jurisdictions. So people are paying attention to the good work that you're doing. You might feel like, well, I can't change jobs now, or who's going to take over, or whatever. At the end of the day, if we die tomorrow, the work will still carry on. So I just wanted to remind everybody of that.
And just one quick comment as we close here. There's almost like a sign of the times when the Surgeon General of the United States puts out a report on confronting health misinformation. It says a lot about where we are as a nation with things that we used to just take as a given. And in that report, it actually does have some tremendously valuable advice for leaders like yourselves who are in positions where you may have individuals throughout your community that are spreading misinformation and what we need to do about it. And it's a hard place to be. We are politicizing things that we never once politicized. Actually, we've always politicized certain things in public health, but this is at a different level, I think, for all of us. And social media and some of the ways that we disseminate a lot of that misinformation has only made it a little bit more challenging. I agree with my colleagues. I think the most important thing you can do, which I think was just said so well, is you have to take a breath and take care of yourself. And you've got to sometimes take a step back and really evaluate the situation that you're in. And to be able to be your best self and to deliver the type of information that people need based on the facts, based on the data, based on the science, sometimes that does take that moment of just self-reflection and that deep breath, which can be cleansing and helpful and really help us move into that next conversation we're going to have, no matter how frustrating it may be.
Great. Well, thank you, all of you, Dr. Kolwalik, Dr. Miller, and Dr. Wooten, for taking time to share your insights today. I believe we've heard, a prescription for good mental health from all of you. And if someone were to take a bullet from each of you and put that on a prescription pad, we've got a good solid prescription. So the importance of self-reflection, self-care. And for those of you in leadership roles, tangibly thinking about what you can do in your organizations to support your employees. These are very, very challenging times, and we can't thank our public health workforce enough for the sacrifices and the hard work and the expertise that you are providing all across this country. So again, we thank you all for what you're doing in terms of public health, mental health, and well-being. So the Public Health Collaborative, Communication Collaborative's mission is to support public health officials by providing communication resources and guidance that you need. So we ask that you please take a moment to answer this final poll question that's popping up here in the Zoom box about resources that would be most helpful to you in the coming months and weeks. What types of communication resources from the Public Health Communications Collaborative would be most useful and valuable? Perhaps infographics or one-pagers, social media graphics or messages, customizable graphics, op-ed templates, advocacy messaging tools, messaging research, tough Q&A content, misinformation alerts, newsletter content, or no templates. So take a moment and respond to the poll so that the collaborative can continue to try to best meet your needs from a communications perspective. We've got about 15 seconds left on this poll. Okay, looks like our results are in, and as you can see, it looks as if those that participated in the poll could pretty much use all of these suggestions, with a lot of need indicated for misinformation alerts. So thank you as well as the tough Q&A content. So thank you for that feedback, and I know that will be really helpful to the collaborative as they continue to try to best meet your needs. Finally, just a word to say that for more resources on communicating about COVID-19, we invite you to visit the Public Health Communications Collaborative website at publichealthcollaborative.org. The resources there include a COVID-19 booster dose toolkit, the FDA approval toolkit, new shareable graphics, answers to tough questions, and misinformation alerts. You can find a lot of that information already available on the website. If there's anything that we can do to support COVID-19 public health communications, please do contact us at info@publichealthcollaborative.org. That website or email box, if you will, is on the screen. And if you are seeking support for your mental health or well-being, in addition to the suggestions from our speakers today, we invite you to please visit How Right Now, which is a resource from the CDC Foundation, in addition to the health and well-being resources that can be provided to you by email. And again, that link is here on the screen. It's www.cdc.gov/howrightnow/. Later today, you will receive a short survey. We ask you to please provide feedback on today's webinar to help us tailor our offerings. And a recording of this webinar will be available later this week. So as we close, again, thank you so very much for your participation today, all that you do, and we look forward to you joining us for our next webinar in the future.